Good evening, ladies and gentlemen. It's a great pleasure to present the first appointment of 2024 with the European Knee Society Hot Topics. Tonight, we will talk about lateral uni. My name is Stefano Rossi, and it's a pleasure for me to introduce the great panel of tonight, Professor Lustig, Professor Beckman, and Professor Cobb. The format of this event will start with a presentation from Professor Lustig, who's going to be the speaker, and then we will have two challengers, Professor Beckman and Professor Cobb, that will start to discuss with him about these hot topics. So I will leave this virtual podium to Sebastian Lustig for his presentation about lateral uni. Thank you very much, Seb.
Thank you very much, Stefano. I will try to. Can you see my screen? Yeah. So
yes.
I will try to convince everyone that lateral uni is actually one of the best surgery we can offer to our patients. And this is true that lateral uni and I will try to show you why when you look at the biomechanics. It is different from the medial uni for sure, but actually it has the potential to give even better outcome than the medial uni. So the first question is why? So number one, just because of the way the skin, and the subcutaneous nerve are, localized, when you do a lateral uni, you do a lateral incision. And we know that lateral skin incision are going to give less anesthesia of the skin and less neuropathy. So that's just one simple reason. Number two, most of the time when you do a lateral uni, use a lateral parapatellar approach. And that's going to include, lateral release, decompressing the lateral facet of the patella. And that's going to displace the ITBL band, posteriorly releasing some of the external rotational tension. Then talking about the joint line, when you do a lateral uni, intrinsically, you're going to obtain an anatomical alignment of the tibia, and the joint line obliquity is going to be maintained because of the shape and the way the proximal tibia anatomy is considered in the valgus. Another thing is the opening on the lateral side of the knee joint is extremely variable. There is actually more opening in flexion than in extension. So that's going to allow more variability in posterior condylar offset. And also regarding the posterior slope, we can be more precise. And actually, this is making it more forgiving when we consider how to restore the anatomy on the lateral side. Also, valgus knees, they love to remain in gentleman's valgus. And we know that for constitutional, valgus anatomy with a slight undercorrection, you have excellent outcome at short, mid, and even long term. And I will show you more data a little bit later. Number 6, and that's maybe the most important one, joint load, bearing is going to be on the medial side, even, with quite significant valgus due to the adductor moment. So that's going to protect actually the lateral femorotibial joint. That's going to allow easier postoperative rehabilitation because the load is going to more on the medial side, and also there is less stress on the subimplant bone during early postoperative period and also long term. So you can even consider this easily, even for some kind of young patient for some specific indication. So that's great, but that's the concept. But then we need to have some data, and we have a lot of publications with long-term data on lateral uni. So they do work even with some long-term follow-up, 15, 20 years. You have excellent survival rate, and this is the case we know with whole poly implant, all design. But you can see that even after close to 20 years, this gentleman was still doing very well, and we published a lot of that. And when you consider, what's the survival rate of lateral uni, it's excellent. You see 80% survival at 20 years. And you can see this is a case from Henri Dejour. It was the old-fashioned technique with the lateral approach, with the tibial tubercular osteotomy. And this is 24-year follow-up. And you can see the polyethylene wear is really minor, and the medial side of the femorotibial joint is still doing really well, and this is at 24 years. So definitely interesting to consider. So the thing I would like to discuss tonight is how should we consider doing this, because again, it's slightly different from the medial uni. So the rule number one is to know the anatomy. It's very important to know what are the slight differences of the medial or the lateral joint, femorotibial joint, compared to the medial femorotibial joint. We know that regarding the femur is hypoplastic in the transverse plane. So when you look compared to the tibia, slightly smaller. So these are consequences where you're going to locate your femoral component. And also the posterior condylar offset is often, reduced, and that's also something to consider, and we can discuss if we need to compensate or to decrease the laxity inflection, or if we need to maintain the anatomy. That's something we can discuss. What is true is there is some mobility on the lateral side, and that's why mobile bearing implants for lateral uni didn't do so well, and this is probably the right, indication for fixed bearing for the lateral uni, of course. Regarding the tibia, usually tibia is not responsible for valgus in primary cases, and the lateral tibial subcortical bone is strongest posteriorly. So that's important to understand when you perform your cut, and also that the posterior slope is different compared to the medial slope.
No, it's
Looks
frozen.
like we have some issue with Professor Lustig connection. So let's see if we can restart his connection quickly. Otherwise, we will give the word to Professor Cobb, who also has some slides to show.
I'll happily. Shall I do that just while Seb's coming back? Shall I? I've got a little bit to talk about. I don't think I'm gonna cause any trouble. Or rather, can you see the screen?
I'm sure it's gonna be perfect. Yes.
Can you see? So I wanted just to start with a statement about why you do a partial knee replacement instead of a total knee replacement, and that is the health of the patient. So revision, the registry, if you live and work in a part of the world where registries make a difference, registries try and prevent you doing partial replacements, mainly because they're so easy to revise. But this wonderful paper by John Goodfellow showed that how, if you look at the revision rate for any given health state of Oxford knee score, a partial knee is 6 times more likely to be revised for the same score. It's a crazy world. So registries are very bad. And this hinge knee is unrevisable. So it looks great in the registry. But this is the reason you should be doing lateral unis, that at 10 years in the Australian registry, 26% of total knees are dead, 13% of partial knees. That's Australia. In the UK, it's the same number. At 10 years post-op, 13% of partial knees are dead, 26% of total knees. Now, of course, you can say selection bias, but you'd have to come up with a hypothesis for who's selecting. And the size of this difference is the same size as the impact of tamoxifen on breast cancer. So it's a huge impact. And my hypothesis, and I want to persuade you of this, is that the partial knee allows you to be active, and this is medial uni data, but it's the same with the lateral uni, that when you look at someone with one of each, you find that the total knee slows the patient down, the partial knee enables the patient, if you like. And so the top speed of people with one of each is the same as a total knee replacement patient or a pre-op patient, not a uni. So it's the total knee slowing people down. And that's why this big difference in mortality. Forget that stuff. Is Seb back in the room, or shall I carry on? If he's not back, I will just carry on. Is that okay, Stefano?
Just carry on. Carry on, please.
I'll carry on. Okay, so these are just a couple of revisions from one, a bearing change, which in our registry counts as a failure, which is sort of crazy. And here, somebody with a lateral unit being added to a PFJ from 15 years ago. In fact, it's a tiny procedure to add a partial knee and a lateral uni. Seb's going to show you some lovely pictures of how to do the procedure. And I suppose the other thing I want to do is just show you some biomechanical data. And this is lateral uni data. We've been publishing about this for a long time. We published the 5-year results of lateral unis, the 10-year results of lateral unis. And why are they better? Well, in the cadaver lab, we did partial knee and then bicompartmental knee and then total knee and measured the extensor moment, both on the medial uni and the lateral uni. And what you see here, and it's a busy slide, but concentrate on the lateral uni, that in near full extension, if you've either had a lateral uni or a lateral uni and a PFJ, you're pretty close to native, whereas the total knees are nothing like it. They're nothing like it. And the reason for that is the lack of the ACL. If you've got an ACL and one meniscus, you can have a pretty good knee. And so if you're looking at, this is now the work output of the knee, medial and lateral unis in walking are just better work output. With on stairs, on slopes, sit to stand, substantial differences in the mechanical efficiency of the joint. If you've still got your anterior cruciate and one meniscus, you're really in very good shape. I wanted quickly, don't want to talk about bicomps, but I did want to talk about biunis quickly. So adding a second uni is a great intervention. It's a tiny extra procedure. And like Seb, you see people who've had unis from long, long ago. Adding a second uni allows them to act. They're not as good as primary unis. They're not, but in the rig, they're nearly as good. And if you look at, so nearly as good, not as good, but nearly as good as a primary uni. And if you look at them functionally, they're substantially better. So adding a second uni, if you actually look at those people, and this is people who had that second uni added to them, they're not as good as a primary uni, but they're substantially better than a total knee. So think about the partial knee as a safe alternative to a total knee, and a world of that. So I'll stop sharing there and hope that Seb is he not back yet? Oh, I hoped he might be back. So my and I don't know about Johannes, you'll have a view on this, but I'm very firmly of the trying to keep you out of the total knee replacement, total joint replacement domain by keeping their cruciates from their extensor mechanism. That way they can have a bigger life than if you've got them into the total knee replacement world. And it's a bit of a fight, but your patients will love you if you do it.
That's true. I can just confirm that. So one of the most happiest patients are those with a lateral uni. Even it's more predictable than those with the medial unis, to be honest, in my hands and in my experience.
Yeah, it's true, isn't it?
Lateral unis are truly the happiest patients. It's very predictable. But maybe...
Will you tell us how? Yeah. Will you? Well, let's just start with your perfect patient has often got a normal standing AP, or not a normal, but no bone on bone in the standing AP. Is that fair? It's only on the Rosenberg or Schuss view. We should say Lyon Schuss view, shouldn't we?
That would be my next question. I think we should start with that, because if you think about doing a lateral uni, you have to do special X-rays. What in your hands is it? Because
I always do that Rosenberg view.
Yeah.
And I think
definitely the indication is
oh dear.
So we're getting lost.
It's like a murder mystery. They're getting killed off one by one. Who's next? I wonder.
Let's see how long we will survive, Justin.
So these days, I think the other interesting thing is more and more people come with an MRI already and without a Rosenberg view. And I think that group of people, I prefer myself to put someone into valgus and feel the lateral meniscus extruding. And importantly, if they're valgus, put them into varus. And does that medial meniscus extrude or not? And if the medial meniscus doesn't extrude in gentle varus, then that's good enough for me. I won't do an MRI if the X-rays are fine. I will go straight into a lateral uni in that circumstance.
Completely right. So
Johannes, what about the ACL? Where are you on the ACL?
If we can preserve it, I always try to. So we're also about very.
If you think it's a little bit deficient, it
doesn't matter. It just doesn't matter. Maybe we have to discuss something how it appears. So if we have posterior wear on the medial side, that won't be good for a uni on the medial side. But if we have posterior wear on the lateral side, that's not a contraindication. And that's what we have to consider. And I think a lot of people don't know that because they just translate medial to lateral, and that doesn't work. And that's the same discussion that you mentioned with your Rosenberg view. Medial arthrosis is an extension arthrosis, whilst lateral arthrosis is a flexion arthrosis. So we have to detect it in flexion. That's the Rosenberg view. And in addition, as the femur rolls back on the lateral side, it's okay if we have a wear on the posterior side laterally.
Yeah, I agree completely. Seb, we lost you. We've also lost Stefano now, but you were just in the middle of your talk. So come on, let's get it back. Have you got it?
Can you tell me where I was? Just
you had got us. We hadn't started operating yet.
Okay, so I start with the surgery. Okay, I start with how? No, with the. Okay.
Stefano, hi.
Hello. I'm problems with the connection. I don't know what's going on.
So.
Okay, I will start with the a few pitfalls, and it's okay, no problem. Yeah. Okay, that's the 24 years. Okay, so I will keep going. So the question, again, is how do we get there? How do we get to the 24 excellent outcome? So I was trying to tell that the anatomy is the key. Lateral condyle of the femur is hypoplastic in the transverse plane, reduced posterior condylar offset. So we have to consider that. And what is extremely important is that the lateral compartment has some natural laxity, and we have to address that. And that's where probably was the limitation of the mobile bearing design for the lateral uni. Regarding the tibia, the slope is quite different regarding the lateral and the medial tibial plateau. So if you consider doing two unis, you will see that the slopes is not the same. And most of the time, the tibia is not responsible for valgus in primary case. So that's not, you really have just to maintain the anatomy. What is very important is the screw home mechanism. That's the key. And we're going to have to consider that when we're going to decide the rotation of the tibial plateau. And when you look at this video showing you the internal rotation of the femur on the tibia, and you see how, there is an internal rotation in full extension, and that's where we need to position the tibial component with some, 10 to 15 degrees internal rotation to adapt to this. So a few key, points regarding the surgical technique. Number one, I like to do a mini-invasive lateral approach with a lateral facetectomy to give me more space to play with. Number two, the physiological laxity of the lateral compartment. There is more laxity in flexion than in extension. We try to maintain that. Don't be afraid of that. And what's important is to be stable in extension and close to extension. And you cannot be equal gaps in flexion and in extension. Otherwise, you're over-tightening the lateral compartment in flexion. You can see here a good stability from extension to flexion, with the tibial tray showing that we've done a good job regarding maintaining the anatomy of the tibia. And you can see here what is very important is to maintain some natural laxity. The lateral compartment is naturally you get some laxity, and if you don't have that at the end, you're probably overcorrected, and that's a mistake we should avoid. I'm going to talk a little bit more about the rotation later on, but you can see here how it's important to match rotation of the femur with the tibia. And we did this publication together with Francesco Dambiacchi and Fabio Catani, showing that with pre-op imaging, you can actually easily match the femur positioning with the internal rotation of the tibia. And usually you have between 10 and 15 degrees of internal rotation. A few pitfalls. I like to show this nice lady. She's a really good indication with bone on bone on the lateral side. But this is a mistake. This situation when you have translation here means that your ACL is gone, and probably you should go more for a total only, unless you have a really elderly patient, and we can discuss that. But this is for me more total only, and this is a really good indication for a lateral uni. Overcorrection. This is absolutely critical to avoid overcorrection when you do a lateral uni. And this is the reason why you have some natural laxity of the lateral compartment, and sometimes you can really easily overcorrect. And this is a mistake we've done. You can see this looks nice, but actually when you look at the alignment of the femur and the tibia, we ended up with probably 3 to 4 varus overall alignments, and probably after a few years we can anticipate some degenerative changes of the medial side due to a surgical mistake initially. Rotation, as I said, lateral compartment is very different from medial, and you have to adapt rotation of the tibial component. And this is showing nicely how when the post-op X-ray, you need to have some internal rotation of the tibia to match the rotation of the femur due to the screw-on mechanism. And if you don't do this, you're going to have that with the femur overhanging anteriorly when you are in full extension, because the tibia is straight and is not internally rotated. Contact points, very important as well. Remember, the lateral condyle is not equivalent to the lateral tibial plateau. So most of the time you have to lateralize the femoral components and sometimes maintain the osteophyte. This is 17 years follow-up, and you can see the all poly implant with a nice contact point in the middle. If you don't consider that, and if you put your femoral components in the middle of the condyle, just like here, well, when you're going to be in extension, you're going to end up with some edge loading and potential anterior impingement, just like here, which is again a mistake you do if you perform your lateral uni just like you do your medial uni. So don't forget to be as lateral as possible. Sagittal positioning, extremely variable. We learned from navigation and robotic that there is no real number. Every single patient is different. Same for the slope. You don't have to aim for 0 slope. You have to adapt to the patient's anatomy, and it can go between 3 to 7 degrees easily, even on the lateral side. I like robotic. I'm obviously biased for that, and I've learned a lot from these different systems, and especially for the lateral uni. We had really interesting feedback from the data we get from the robots, and they did help us to avoid early mistakes. And we found that with the robotic we have less early revision because we would avoid the surgical mistakes I've been just mentioning previously, because you can really control all the different parameter, and it's surprising I will show you the videos, what kind of outcome you can get for these patients at 2 months. It's always impressive to see how the biomechanics of the lateral uni is extremely favorable, and you can have a forgotten knee after just a couple of months. So why pre-op imaging is interesting. I will show you briefly a video of the technique. This is a typical indication, and I will show you all the different tricks I mentioned in this 2 minutes and a half video. You see the lateral approach. I make sure to have a nice view. You can see here, even with the lateral approach, you can really nicely see the condyle. You can see that the disease is really a mid-flexion disease. I perform my lateral facetectomy. Then, because this is robotic, you have to put the pins. This is going to be a navigation of the robot. You can see how, with the prop imaging, you can have a pretty good understanding of the anatomy, and you can plan. That's the interesting part. You can really mobilize the knee. You can make sure you're going to adapt positioning to try to have the knee stable in extension, match the rotation, as I'm showing here. Make sure you have a good contact point through all the range of motion, and then you do the cuts. With robotic, you use a saw, you use a burr, you use whatever you like to use, but you see that you can actually do it without so many retractors. We do have a pretty good view. You avoid to flex the knee. You try to maintain the knee close to extension, just like I'm showing here. And then you can do the final try. You make sure there is no anterior tilt of your tibial component, even in deep flexion, and then you can finish the job. It's really important to pay attention to, remove all the blood and to have a good cementation technique. I like to use the double cementation technique, even for my uni. I've seen too many early failures of uni because not because of the cuts, but because of the poor cementation technique. And if you use cemented implants, you really have to pay attention to these, final steps of the surgery. And you can see here how there is some internal rotation of the tibia and how the femur is well centered on the tibia. And this is, again, even for a slightly obese patient, what you can get at 2 months, which is, and I'm sure, Justin and Johannes will agree with me, is much better than what you can get with a total. So just to finish and to show you how we are enthusiastic about this, a few challenging situations. Post-traumatic osteoarthritis is usually in young and active patients and is a challenge. You can consider tricky options like massive allograft, but we published now more than 10 years ago that actually lateral uni is really good in this situation. You can see here how using a couple of screws to enhance the fixation on the tibia, it can work. This is a story of a 38-old guy, 14 degrees valgus, post-traumatic. We did a uni. This is the post-op view, and this is him 15 years later. He's 53 now. He's still very young. You can see the helmet. He came with his motorbike just to say hi and tell me he was happy at 15 years. And I'm pretty sure I will not see him for the next 5 or 10 years. So that was a pretty good option, even for this 38 old guy. We do have long-term data on that, and we know that even for this young patient, lateral uni is a good indication. Final aspect, really a tough case, 18 years old, post-traumatic. You can see him walking. He has terrible condition. Again, because now we know the long-term outcome of lateral uni. This is what I could give him, and you can see him at 1 year, and now he's 3 years down the line with back to his normal life, just by considering the different aspects I just mentioned during the surgery. So definitely, I think lateral uni, and we're going to be open for discussion, of course, is a really, really nice, option for a patient. You need to understand anatomy, biomechanics, but they are on our side, actually. You have great outcome even in young and active population, and I think, robotic can help. Thanks a lot for your attention.
Great.
Thank you very much, Seb. Thank you very much for the great presentation.
You start, Johannes.
Raising his hand, so the word to Johannes.
Thank you. Great talk as expected. To be honest, I think we don't have just cracks in here. So before you start with the post-traumatic ones, what is your daily work up for those? What do you do? I think so. So when you were off, Justin and I just said that Rosenberg's view is mandatory.
Absolutely.
Rosenberg's view for a flexion view. But what do you consider with stress views, stress X-rays? Do you need them? Do you always do them? Because I think they are important as well, especially for those who start with to know how it opens up, does not, closes medially, and so on. Maybe you can give us some insights. What do you think about that?
No, absolutely agree. Usually we have, long leg films to understand overall alignment, stress X-rays to understand reducibility of the valgus. Rosenberg view, 100%. Lateral OA is a mid-flexion disease. And you might miss it if you don't just have, frontal and lateral view. And that's probably why some people, they just don't realize this is a lateral OA and they miss the indication, and they're going to tell you, we never do lateral uni because we don't see this patient. Actually, I think they see them, but they don't catch them because they don't do the Rosenberg view, and which is a pity because we know that they have excellent outcome and long term, as I try to show. We do skyline view as well, but as probably all of us, we don't pay so much attention to the patella unless I have bone on the medial side, and I might be worried. But even though if there is no symptoms, I'm going to go for lateral uni anyway.
Justin, do you want to step in?
Yes. So in London, we do the Lyon-Schuss view rather than the Rosenberg. I'm trying to be amusing.
Yeah, we call it the Lyon-Schuss view as well.
Good. Because at Rosenberg, he learned about it in Lyon from Philippe, I think. I believe this is true. Anyway, so I wanted to talk about the two different sorts of people. First of all, the slightly hypermobile people. So the tall supermodel types who are quite flexible, they go valgus. They seldom go varus. Those tall women, it's a very common thing, but they're hypermobile, and they're the ones it's very easy to overcorrect if you're just doing by tension. And I thought it was a lovely talk, Seb. Those people, you have to leave them really loose to avoid putting them into varus on the table. So there's the hypermobile, and that's a different group from the people who have a chalet in the Alps and they do a lot of skiing, who have just crushed their lateral compartment, because you can treat them a little bit more like a regular, like a medial uni. They are different people. So I think you should, in your evaluation of the patient, how flexible are they? If they're on the way to hypermobility, you better use a fixed bearing, of course, but overcorrection is very easy to do by mistake because they're so flexible. So I think that's one domain of identifying the patient. And so the tall woman, the tall flexible woman, a Rosenberg is a very important part, as Johannes said. The next thing I really wanted to bring up from your talk, Seb, is why you stopped using an all poly tibia, because it seems to me the all poly tibia, it's a great indication. It's really not loaded very much, the lateral compartment, if you do the operation right. It lasts. No one's going to do better than those all poly tibias from Cartier and Urbaniak. It's an interesting one, isn't it? That you can't persuade, apart from, I think, the St. George sled, nobody else will give you an all poly tibia. Is that true?
No, you can have all poly tibia. Some company can still provide you with all poly tibia, but the thing is, we had some pretty bad experience on the medial side, so that's why for the lateral side, immediately. So that's why we were like, well, we're going to stop that. But I do agree with you. The long-term outcome on the lateral side with all poly is amazing, and I'm not sure we can challenge that or do any better. And the beauty is when you see this guy coming 15 years later and he has minimum wear and he still has 8 millimeter of poly, probably he's going to look fine for another 15 years, and that's great. So I agree, for lateral uni, all poly would be interesting. Now the problem is we are using robotic, and so we don't have the option of all poly. That's maybe a reason why we shift towards metal back. But the metal have less poly, and potentially with where you can have metal on metal. The other thing is with a metal back you can do a poly exchange, like I think Jean-Noël published a couple of cases. So there is pros and cons, let's say, for both, but you cannot challenge the long-term outcome we have with all poly for now. I do agree.
So in our intermission, when you were in the bar having a beer, Johannes and I were talking about indications and the anterior cruciate ligament. In my practice, in the older patients, I don't mind about an ACL deficient knee if they're an older, less active patient, because it feels like the lateral compartment is protected by the sensor mechanism. It's not, if they're not unstable, if they just got lateral arthrosis, whereas in the younger person, then the pattern of wear is more challenging, isn't it? Do you have a rule about the cruciates and lateral arthrosis?
So more and more, I follow exactly what you mentioned. I try to, avoid paying too much attention on the ACL status for elderly. So then we have to define elderly. What is elderly? And then otherwise, I would just combine with an ACL reconstruction, also for lateral. And it's and also what is interesting, we have a lot of these patients who had a previous ACL reconstruction with a lateral meniscectomy, and they come back 15 years later with a lateral. This is a great indication for lateral units. It's perfect indication for lateral unit. So no, we used to be afraid of ACL insufficiency much more, and as long as you don't have the fixed translation of the tibia, I think it's reasonable. And as I try to show the outcome of a lateral uni compared to a total only, there's no comparison, functional outcome.
Johannes, do you want to step in?
So next topic, and it's also because I just saw an incoming question from the audience, and I would just highlight that question and maybe put an additional one in it. So what about, so we all agree that we need undercorrection, but maybe a few sentence, because that's the question: why do we accept or want to be in valgus and not straight? Because with the total, we always, or we try to get straight, although with kinematic alignment, we start now with slight valgus, but no one agrees on that so far. First. Second, so one on the alignment of the whole leg. But next thing is, you're from the French school and you love the Cartier angle on the medial side, which follows slightly to the MPTA. But there is a LTPA as well. Do you put it always straight 90 degrees, or would you also agree to put it slightly in the varus or not? What is your suggestion on that?
So I will take the second question first, and then the first one. We learned a lot from actually pre-op imaging, from pre-op CT. From that, we learned a lot. That actually the proximal anatomy of the tibia. Yeah, can you hear me?
Yes,
perfect.
Absolutely.
Just got lost.
So proximal anatomy of the tibia. Sometimes you have some varus on the tibia. That's true, but it's quite unusual. But when we try to maintain, just like for the medial uni, we try to maintain the Cartier angle. But most of the time we end up close to zero. To be fair. So it's not so frequent to have to really put the tibial component with some slight varus. It does occur 1 or 2 degrees. I would not be afraid of that. To put the tibial component in valgus is even more unusual. So usually we end up close to zero.
I would say it's an absolute rule: never valgus, never ever valgus. The uni, you shouldn't, a neutral, never valgus. For me, I would say that's a rule.
I agree. And again, when you look at the
orientation, obviously the knee angle is about about how thick, but the orientation for me never valgus.
Yeah. And we have the same conclusion. We used to follow the rule, and then looking at the anatomy with 3D imaging, the rules are right. Let's say so. It's good when it's like this. And then the question about overall alignment. Sure. Yeah, go ahead, Justin.
Yes, Justin, step in. Do you want to comment?
Could we? Yeah, I want to talk about overall alignment and maybe correct. obviously, we all know about HTO for varus knees. We are all enthusiasts for the lateral uni. I think the distal femoral osteotomy for a valgus knee is a really bad idea, because it's in the wrong place. It's in the extension plane when the problem is inflection. So in our group, I think, like as Seb showed, even in very young people, we will do a lateral uni because of rather than a distal femoral osteotomy for someone who's constitutionally valgus.
Yeah, I agree that the distal femoral osteotomy is always in extension. It plays a role in extension, and we have to consider, extension and flexion for the case I showed, and that's why we didn't go for osteotomy. The question about overall alignment and the difference between toll only and uni, I think is wrong. I think we showed with Cécile Bataille our data on valgus, and actually when you have severe valgus pre-op deformity, they do better if you maintain some slight under correction. And we have like, I think, 800 cases, so it's quite significant. But when you start with some mild or moderate valgus, then you can go close to zero when you do a toll only. So for uni, it's the same. So you just consider the intra-articular part of the deformity, and you maintain some slight valgus deformity, and they are really happy, and the biomechanics remain physiological. And so for me, it's not contradictory. I think what was wrong is to do mechanical alignment for everyone. That's for sure. And we have different options now, I think. And so the uni was, we were doing right before, understanding why we were doing right. But it is the same philosophy. So for me to maintain some slight undercorrection makes actually a lot of sense. And we have to be careful, just like Justin said, when you have some hypermobile patient, and the risk is to overcorrect them. That's why stress X-rays are important. And for me, I have a rule: when there is less than 5 degrees of pre-op deformity, I tell my young guys to be very cautious, because that's where there is a risk to overcorrect. When there is more than 5 degrees, usually it's pretty hard to end up with some post-op varus alignment. So I'm more relaxed.
Johannes, before giving you the word, just let me do ask a little question to Seb, because the group of Romagnoli just published a paper on lateral unis, and they say that a higher undercorrection give better results than a lower undercorrection, like saying that they do better when the valgus residual angle is between 6 and 9 than less than 6. So this is something in the middle on what we were saying. And this has been published last year on Journal Arthroplasty.
So yeah, again, I think you just have to consider every patient's anatomy. And so I think we all agree when we talk about uni, to say, oh, we should aim this angle for alignment, it means that we don't understand what we're talking about. I mean, uni is about intra-articular, to correct intra-articular part of the disease, and what is extra-articular remains the same. If you correct into the joint an extra-articular deformity, I think you misunderstand what is a uni. So maybe conclusion from Romagnoli was about high volume, and this is what they found, probably because in their population that was the right target. But I don't think we should say we should aim 6 degrees of residual valgus. I don't think it's the way we should consider that.
I totally agree with you. Johannes, you wanted to add some comments?
Yeah, we are here to challenge you. So now you have a valgus knee. I personally always do stress X-rays to see whether it opens up or not. I think you maybe don't do it all the time. So how do you think, or how do you address your correction? And second, you always do a second lateral approach. So you always release the iliotibial band. So you always get a release of the extension. So what's, or to which extent do you accept valgus? And if you don't do stress X-ray, how do you see, or how do you address how it opens up and that you can address this with a lateral uni?
Yeah, so few comments. With the robotic system, you actually do the stress during the technique with the navigation. So you actually see what you anticipate from the stress X-rays. So if you use navigation or robotic, you probably don't need stress X-rays because you're gonna have the same data during the surgery. Then if you use stress X-rays, just like I do and you do, you can actually anticipate that. Otherwise, clinically, when you assess the patient, you can also have a pretty good understanding of the reducibility or not. So 3 different ways to do that. Then again, if I'm afraid of overcorrection, that's where also navigation is interesting because it gives you the exact number of alignments and you avoid mistakes.
So I think, Johannes, you were talking about the medial collateral opening in valgus. Is that what you were asking about? So in my experience, in full extension, then it's very unusual to find a lot of laxity, whereas in 20, 30, 40 degrees, the medial collateral may open up. The medial side may open up, but it's not a malignant thing. And once you just do effectively measured surgery, and the medial collateral, I think, restores itself. I don't think you have to cut the knee out just because it opens up a little bit in stressing.
But
me.
to my personal view, it's important that the lateral one opens up.
Oh, of course. Sorry. Yeah.
Correct. Yeah. Otherwise, you're gonna end up with the same valgus deformity, and that's where you might have too significant undercorrection. But if the MCL is really insufficient, then it's probably not a good indication for lateral uni. I totally agree with that. Yeah.
So the other interesting group. Can I just quickly mention the people who
yes,
are
of course.
5, 10, 15 years after a medial uni, they come with that lateral compartment failure. They've been too much skiing, too much tennis. That group, they were naturally varus to begin with. So I think what Sergio's group showed absolutely in the valgus knee, leave them valgus. But if they're valgus and they had a medial uni already, that means they were primarily varus. So in that group, put them back into varus with adding a lateral uni, because that is a lateral uni is a great operation primarily, and adding it to a medial uni, if that's the right indication, is also a great procedure.
Sure. Yeah, absolutely. And you go back to the previous alignments, which makes sense.
We have a question from the audience. Could you give some advice how to set the level of the section at the tibial side? Do you have any bony landmarks? How to use the stylus? If less is more, of course, if you don't use a robot and you're using a traditional technique.
So I can tell you from the mistakes we've done, what we learned. Every time we did a mistake, we removed too much bone on the tibia. That's the classic, let's say. Then you change the joint line. You end up with some pretty bad, bone quality.
But that's the medial side as well, right?
Oh, correct. Sure. That's true for both. But for lateral, you are really on the lateral side. It's even easier to make a mistake. So I would say is right. Less is more. Be conservative, and it's easier to recut 1 millimeter than to put the bone back.
So I agree, and I think a first cut. One company has a technique where they suggest you do a first cut and then you do a measure resection off that first cut, knowing it's not enough because it's so bad to take too much. And if you look at the CT of the proximal tibia, the stiffness of the bone drops off exponentially with every millimeter. And so if you're putting in a 6 millimeter, with the Oxford, it would be a 6, but every millimeter of thickness of poly is increasing revision risk. So the minimal tibial resection, not undercorrecting, but minimal resection is really important.
And that's something we learned from the Oxford, experience. You can play a lot on the femur side with and it's easier, of course, when you have some specific device, and as I said, robotic is making it easier. But I don't like to jeopardize my cuts on the tibia side. I don't like to recut. I try to be really conservative, and since we understood that, I mean, we have the early failure almost disappeared. I mean, doesn't mean that indications needs to be well understood, but now we are more about the long-term aspect, and the short-term failures, most of them were due to technical mistakes. So if you are conservative on the tibia, you get 10 to 15 degrees internal rotation, and you put your femur laterally. That's only 3 things to understand. Honestly, you have a great surgery here, and I agree with Justin. Lateral unis are doing so well, or primary for when you add it after a medial uni.
Johannes, do you want to add a comment? Yes.
Not a comment, another question. So that was the level of height of the resection. But what is very, very important and challenging in the beginning, so we all do quite a lot of numbers in lateral unis. However, how to set the sagittal cut? Give maybe the audience an advice, because in my opinion, that's the most critical part in the beginning, because you're always, even if you think you're medially, when you start, you're still laterally. What is your advice taking this sagittal cut perfectly?
So yeah, that's one of the main issues. The problem is the patellar tendon is pushing you to have not enough internal rotation, so to be too lateral. So there is a trick to go through the patellar tendon with the reciprocal control, but I don't use it. I think if you go in a slight extension, the problem if you're in flexion, you have the patellar tendon, but if you operate in slight extension and you use a retractor, you can perform the sagittal cut also, not easily, but it's not so challenging. And as long as you understand you need to be with this internal rotation, you will be able to manage that.
Would you also agree that in the beginning just do the incision a little longer, that you can more easily put the patella aside?
Oh yeah, absolutely. Make sure you have a nice view. You saw my video. I see well. I see my condyle.
And that's the 2 different people, isn't it? The flexible woman and the stiff man with a huge patella, even with some Baha, make a huge extension into the quadriceps. It's fine. It's not that you're not really cutting important tissue there. You're just splitting the lateralis tendon. It's fine to really extend that a long way.
A nice trick is to put when you begin, you can put a needle through the patellar tendon, and then you see the correct direction, mark it, and then cut it. I don't like to cut through the patellar tendon, but if you put a needle through the patellar tendon, you see the correct direction. You can mark it with your intercautery, and then you can perform the cut in the correct way.
Yeah, no, absolutely. This is critical.
We have a couple of questions from the floor. The first one is, what degree of flexion do you perform STREX X-rays, as it is a posterolateral osteoarthritis? So this is a very quick question you may want to answer to.
Yeah, we do. We just like we do for medial lateral, we do the same slight flexion, not hyperextension. So we do slight flexion, and we do the STREX X-rays with the telos.
That doesn't work in extension, to be honest. It doesn't work in extension, so slight flexion. But that has, because I also see the question, that has nothing to do with the Rosenberg view. So we don't want to detect the lateral arthrosis with this. We just want to see the open up or closing down. But to see the arthrosis, we then need the Rosenberg view, which has more flexion. So we are talking about 45 degrees. And with those STREX X-rays, we're talking about 10, 15 degrees, right?
Yeah, absolutely.
Another question from the floor. Can we ignore partial thickness chondropathy of the medial side on an MRI scan? So do you take an MRI scan and what you do with this?
So no, I do X-rays, and if I'm in doubt, I would do we do ultra CT scan. So I've learned that from Manu Tiampon, and I kind of like it. It's for me, it's a nice way to show the patient what I'm talking about. I don't like to ask MRI because the radiologists are gonna always tell me there is something wrong somewhere to push me to do it only, and then it creates a problem. So I don't pay attention if there is a lateral way, lateral knee pain. X-ray we mentioned. I'm totally fine, and I never for me. People who ask an MRI, they want to find a good excuse to do it only.
Okay,
that's right.
Okay.
The sports guys who are repairing the lateral meniscus without doing a Rosenberg view, they're bad guys.
So we have 1 minute left. So just one very quick question. What about dedicated implants for the lateral side? Do you think we need them? You can still go for a lateral one from the medial one used on the lateral side from the other side. What do you think about this?
No, I think
I would say,
yeah. Go ahead.
You first, Seb.
No, I think that we use a medial implant from the other side, so the natural curvature is not designed for lateral uni, and I'm not even talking about the tibia, which also is not designed for that. So, and I know Johannes, you have a huge experience with custom implants. So, I would love to have a lateral uni designed to be a lateral uni, but the systems I'm using, they don't allow me that.
So Seb, robots, you have a life outside of robotics, just so you know. So several companies do lateral unis, special tibia and femur, and it's definitely worth it. It's definitely worth it.
I agree.
It's more forgiving.
Unless you agree too.
And better coverage on the tibia, more forgiving.
3 companies now, at least. So 3 I'm aware of.
Unfortunately, they don't have a robot for Seb, so he's stuck.
Okay, a quick question from the floor. What do you think about medial approach for lateral uni?
So we had a wonderful session at the partial knee meeting with Andrea Baldini showing us a video, and he almost convinced me. Almost, not totally. Honestly, he showed it. It looks really nice and easy, but not to be serious. You can do it, but I don't think it makes so much sense to me. But this is a lateral disease. I mentioned all the different reasons why I think doing a lateral approach makes more sense. So, but he made a really nice video, to be fair.
I was there. He could almost convince me as well. But again, that was what I mentioned before. With a lateral incision, you always are at the tubercle of Gertie, and you make slight release of the iliotibial band, and that makes sense to me, especially in severe valgus, because then it opens up in the problem you have, and that's the extension. It always opens up in flexion, but the extension is the problem.
Okay, so I think our time is ended. It's 8:32. So I'd like to thank the fantastic panel. It's been a great discussion, and I will invite you for the next hot topic from EKS, which is going to be the 4th of March. And the topic is going to be sports activities after uni and total knee arthroplasty. So you're all invited, and we hope we're going to have a great audience. The faculty and the panel is going to be great. So I will not tell you tonight. You will see in the ads we will publish soon, and see you next time. Thank you very much to all of you.
Thank you very much.
Hi, guys.